starting the recording of today's session. So it's 2:00 p.m. in Paris on Geneva time. So we are welcoming you for today's webinar. So I would like to invite you to type www.menti.com in order to participate actively and use the code 63825. So this is one of the series offered by WHO in data quality improvement, and is offered by WHO Scholar, which is a program. What is Scholar? Scholar is a program of courses starting since 2016 by WHO, intended for immunization professional working in countries, and the aim is to present WHO new guidelines and help professionals to translate these guidelines into action at their place of work, whether it's region, district, or national level. We really want you to take these guidelines and translate them into action. And we have already a lot of cohorts since 2016, more than 5,000 professionals from English-speaking countries, but also 3,000 from French-speaking countries have already participated in that course. And we have more than 2,000 projects that are, some of them are implemented now, and we're really happy to also announce that we have like 400 companies, and our companies are professional as you are, who successfully finish one courses and get their certificate, but they didn't move from the scholar program. They stay there to support new scholars. So we really encourage you to apply for these courses. They're really interesting, and we hope that with this course you can contribute actively to improve immunization coverage where you are working, whether it's a district, regional, or national level. So without further talking, after Menti.com, you also have Zoom, which is in front of you. Zoom is a software that you are using to attend to this webinar. So we have some ground rules here. As I was saying, we really want you to actively participate by listening the presentation and also present your experience and give the feedback. And you will use a small box that you see in front of you, the chat button. So go ahead, use that chat button to give your feedback. But also you have also another small box that is the Q&A. The Q&A is where you can type the question related to the topic of today, and then, or if you don't have a question, you can also vote for the question that might interested you. Again, we will share the slide, the link to the giving you access to the slide. So all the resources are available, as you know. So here you can see now that in the chat box, you please go ahead and choose the option all panelists and attendees if you want your comment to be seen by all. But also here you have, that is the visual of the Q&A. That is the Q&A that we encourage you to hit if you want to ask your question, or you can see that small thumb with that small hand with the thumb up. Click on it and you'll be able to vote. Please, we encourage you to really vote for the questions that you would like the expert to answer. And also here we go now. So today's today. So we are having the 6th of the series of these webinars offered by WHO. We will be talking about the denominators and GIS, and we know how important it is for you, and we really encourage your active participation. Now I would like to turn myself to Jan Vrevedon, who will present us who is here with him today. And I know that there's a lot of experts. I'm really excited myself to listen for all the exchange, and we encourage you to participate. Good afternoon, Jan.
Yes, good afternoon, Alain, and thank you everybody for joining again so numerously, people from all over the world again, and it's really good to see you here again. So this time we'll talk about denominators, and we'll have a special session or a special section on geographical information systems, and that is going to be presented by our colleague Rocco Panciera, and I will let him introduce himself first.
Hi, good morning everybody. Can you all hear me?
Yes.
Hi, my name is Rocco Panciera. I'm a GIS specialist in the Implementation Research and Delivery Science unit of the UNICEF Health section, and I have more or less 15 years of experience with application of geospatial data and technology for environment, volatile monitoring, and for the health sector. And it's good to be here with you and to share experiences with you.
So thanks, Rocco, for willing to join and get up a bit earlier for that. Also, I see that Carolina is in the room and maybe Marta. So if you want to just quickly say hi to everybody as well.
Hi, this is Carolina Danovaro. I'm here with Marta Gachik-Dobo. Marta, you want to introduce?
Good morning, everyone. I'm Marta Gachik-Dobo. I work together with Jan and Carolina in the Strategic Information Group in Geneva, and I'm very excited to be here.
So thanks everybody for joining. Marta and Carolina are also in New York, so also had to get up a little bit early. Just to say that, so today we're going to talk about population estimates, denominators. Where do we get them? Then we'll talk about what could possibly go wrong with estimates, and then some kind of tips to improve target estimates. Then, as we said, we will talk about geographical information systems. So a lot of, you may have heard a lot about kind of use of satellite imagery and digital maps for all kinds of reasons. And a lot of this work is very exciting, but we've also seen that a lot of it hasn't really reached scale yet or hasn't been used in many countries. So we want to find out from you also kind of, is this interesting? Is this potentially useful? And what would it take to implement this more widely? Then also, as always, we would like you to share your experiences, whether those are challenges with denominators or things that you have done to better estimate your target population, or even if you have used GIS, geographical information systems, in some shape or form. I'm also happy that Marta and Carolina are here, and I think they will only be here for the first hour because then you have a meeting. Because Marta and Carolina are both statisticians who know a bit more about kind of the finer details of population estimates and demographics. So if the questions become too hard, I'll be happily turning them over to you, Carolina and Marta. Before we kind of start, we normally do kind of a little quiz to kind of get your opinion and get people warmed up and get you thinking about some of the issues. And let's grab menti.com. So if you want to take your phone or your computer and navigate to menti.com and tell us if you think you agree or not, whether good denominators are required for monitoring coverage, to monitor equity, to estimate the number of completely unreached, to estimate dropout rates, to perform good micro planning, and to do vaccine procurement, planning and distribution. So 2 people already voted, or a few people already voted, and everybody thinks that denominators are very important for everything. So again, monitoring coverage. So everybody seems, well, let's wait a little bit because we only have 11 people out of the more than 200 on the webinar already. But so far, I think you're right. Monitoring coverage, you really need denominators for. For monitoring equity, if you think about it also, because denominators is nothing more than a population estimate. And if you want to monitor coverage in a specific population, you need a more specific population estimate. So that's also probably true. It's also very important to estimate the number of completely unreached, because the completely unreached are the ones that you never see or find. And the only way to actually see if you kind of involve them is actually by having a good population estimate of your entire country. And of course, the problem then is you need some other mechanism where those unreached can be found through a census or something else. Estimating dropout rates, that was a bit of a trick question, because actually for a dropout rate, you don't really need a denominator or a target population. To be honest, you need a denominator, but not a target population, because a dropout rate is only dependent on the difference between a first dose and a third dose. So you could actually work just with numerators, even though technically, of course, one of the numerators then becomes a denominator in the calculation. For micro planning, yes, very important that you know how many people you want to reach and then develop appropriate strategies for that. And finally, for vaccine procurement, planning and distribution, it happens from the top down. So Gavi estimates the need in vaccines, for example, using denominators. And then in countries as well, it's often distributed according to population estimates to make sure that enough stock is available for all population to be covered with certain vaccines. So on the whole, yes, denominators are extremely important for our program, and they're also sometimes just a little bit challenging. Second question in the quiz. Can you tell us whether you know whether your denominator that you use in your context, is it derived from census data? Is it derived from a civil registration and vital statistics system, CRVS? Is it based on local enumeration, so kind of head count, or don't you know? And what we see here is that for most people, it all goes to the census data. So most countries use census data for population estimates. There's also a few countries that use a system of local enumeration, so local head counts, where, for example, the health worker goes out every December or January of the year and find out how many households there are and tries to do a household listing and uses that actually for her target population estimates. And that is often then also reported up and used at a higher level, like at the district for denominators. There's one person who says that in their country, the denominator is based on a civil registration and vital statistics. I saw somebody from the Netherlands participating, so that's maybe you. And 3 people don't know. And this is probably a fair understanding of what we think is the most common way, which is through census data. A final question in Menti. Do you think in your context, whether denominators are good enough for the mentioned purposes? So the things we said in the beginning, monitoring coverage, monitoring equity, micro-planning, are your denominators good enough for those purposes? Do you think you know where denominators come from, how they are calculated exactly and precisely? And finally, do you think that you as a program or an HMIS person, you are empowered to make improvements to your denominators? And here kind of the opinions start to diverge. That's quite interesting as well. So let's see what comes up. So even though many people experience problems, a lot of you still think that they are good enough. But to be honest, here in this distribution, we can also tell that quite a lot of people think they're absolutely bad or just a bit bad or neutral. So it's really kind of all over the place. So denominators in some cases are good enough, in some cases they're not. We know in many cases they're really kind of problematic and probably not robust enough, for example, for vaccine distribution or coverage calculation or even micro-planning. Most of you actually know or have at least some ideas of where they come from and how they're calculated. So that's good. Then I keep the slides about that pretty short. And finally, and very important, that's program people or Ministry of Health people in general are not often empowered to make improvements to the denominators. So even if you think you can actually refine them or find better sources or change things in denominators, the fact is that we often have to take the denominators for granted and actually use the ones that the National Bureau of Statistics give us, and we're not really allowed to use something else. So even if we know how to improve them, we're still facing this fact that we'll have to work with other people to actually improve the denominators. Right? So that's also very important to note. And thanks all for voting for that. It's very interesting. I have one more quiz question. Sorry, I thought I'd take this out, but let's talk about census data. Since most of you actually say that denominators come from a census data, what do you think the biggest problems are with census data in your country? And here it's a system in Menti where you can choose either one of these problems or give points to each of them and kind of weigh them. But I gave you 5 reasons of why census data might not be perfect. And you tell me what you think the biggest problems are. So first of all, censuses are often done for political and financial reasons, not necessarily for public health. The estimates might be outdated as people move so much. People might be counted in places where they don't live. So actually migrant workers, for example, they live in some district, but they're counted. So they live in the capital, for example, but they're counted in the district where they come from. They might miss informal settlements and slums, or they're not frequent enough. All right, let's start with the first one that starts to kind of drive on top. So censuses are indeed often done for political and financial reasons. So they're meant to kind of sustain a political balance in a country, or they are very important to allocate national government resources. And then the problem is that it becomes so political and so important that the data quality in itself of those censuses will be variable. And this is a huge problem in many countries that we know of. and it won't necessarily be fixed soon. The second one that you mentioned is that estimates are outdated as people move so much. So you make a census and then next thing you know, like everything has changed because there's kind of migration, urbanization, there might be conflict, and kind of this kind of messes up the entire denominator, especially the distribution within countries. They're not frequent enough. That is true for some countries. Some countries have not had censuses since the 70s, I think, for example, for Afghanistan. Other countries actually do it every 10 years. So it's a mixed bag. For some countries, that's a very big problem. For most countries, it's not anymore. People are counting places where they don't live. You don't think that's that much of a problem. And censuses miss informal settlement and slums. You also don't think that that's that much of a problem in your country. So, but yes, so 1/3 of you, or 1/3 of the votes go for the political and financial purpose of censuses and not the kind of objective count of people. Fine, so with that being said, let's then look at what the sources of population estimates might be. So the first is census projections, which we talked about. The second one was civil registration and vital statistics, which we think is a very good system. It can be very robust, very precise, but unfortunately it's not really well implemented or complete enough in most of African, Asian, or middle-income countries that it actually can be used for denominators. Local enumerations and headcounts are also possible, but we kind of really advise people to be very careful with that system, because if you use local enumerations or headcounts, you really need to make sure that nobody is missed. And since the local enumerations are often done by the same people who provide services, you will have an inherent bias. So the people who are missed by the service will also be missed by this headcount. So this is why we don't like that system as such. But in some cases, it might be the only thing that is reasonably available to people, because census projections are so much out of date, for example, or in an urban setting, the population is so much underestimated that this is really the only way to get a local target, for example. Then there is an idea to use service data, for example, antenatal care visits, or BCG vaccinations, or Penta-1, as a denominator for further immunizations. And that has a bit of the same problem, that it has bias. So we will, with that kind of system, not detect the people who are never reached. So the zero-dose kids, which become more and more important in our program, to really find the last children that are not vaccinated, that is not a good way to find those. And finally, all these new technologies like satellite imagery, or even mobile phone data, where people move and you count the connections to antennas and everything to get an idea about how many people live and move through areas. That's also something that's coming up, but it's probably a little bit more futuristic at this point. But we will turn to Rocco in about half an hour or something to talk more about possibilities, at least for the first part, the satellite imagery part. But these are all the kind of sources we could think of in terms of where do your population estimates come from. But at this point, since we know that most of you actually use census projections, we will talk mostly about that, and also because those have like some statistical challenges, let's say. So the math is actually quite easy, and I will just present this and talk a little bit about the challenges, and then I'll ask Carolina and Marta to kind of chime in on the challenges with that. But the math is quite easy. Like your live births, you can just calculate by multiplying your population with a crude birth rate, right? That is during a census year. For future live births, you just take your previous year in live births and you multiply that by growth rate. So you have that grow by a birth-specific growth rate. And then finally, we use surviving infants in our program, not live births often. So we need to adjust the live births for the infant mortality rate. So we deduct the infant deaths from 100% to actually get to an adjusted estimate of your target population. So as such, this is actually quite easy. It's just a number of formulas with very few variables that you have to apply and come up with a denominator. Now the problem is that everything you see here on this slide can be problematic. Each of these indicators can be problematic. And we'll just go over each and one of them, and then I'll invite maybe Carolina and Marta also to chime in. So what could go wrong? So first of all, your census might not have been that great, as you mentioned. It might have been old, or the methodology might have been not that great, or there was no funding, and then your population estimate in itself is not so robust. So the population estimate in itself is kind of off. Second thing that can go wrong is that crude birth rate. So it looks easy, but it's actually a very difficult number to get a hold of. So we know that kind of the countries in the world, they range from like 1% or 10 per thousand to maybe 450 per thousand crude birth rate. But it's really kind of hard to find out what the exact number is, and it also changes over time. The important thing is it needs to come from a census or a survey, and it needs to be adjusted from that. And that adjustment is something you don't want to do at home. It's apparently really difficult, but it's not an easy thing to get even through a census. The third thing is that growth rate that we talk about is really difficult to forecast. How will a population grow? And more importantly, in what places will it grow faster than in other places? That is really not easy to get to understand. And here on the left side, I just put as an illustration the population pyramid for the world as a whole in 1950, in 2015, and projected for 2100, so 80 years from now. And what you see here is that, yes, in 1950, the population pyramid was really a pyramid with a lot of young people at the bottom and relatively fewer older people at the top. Right now, it's not really a pyramid anymore. It's kind of more of a bell-shaped curve. And in 80 years, it will actually look like a high-rise building, not like a pyramid at all. So what this shows is that even for example, the population growth in the world, even if the population in the world grew quite fast, things happened so that maybe the under ones or the under fives didn't grow quite as fast. So the CBR, the crude birth rate actually shrank over the same time. So that's a very important thing to understand, that growth rates in births can be very different from population growth rates. So there are certain countries with very high population growth rate and very low crude birth growth rate. Right?
Jan?
Yes,
this
please.
is Carolina. If I want to give an example here of a country in Latin America where everything had been estimated assuming that what was happening until one point. At one point, a lot of people got out of that country, but not only any people, but mostly people in reproductive age. Therefore, the number of children being born was less because there were fewer parents, if you would. So even though the people were having sort of the same rate of children as they were before, there were fewer people to have those children. And it really produced a big problem for EPI because in that particular country, the denominator was overestimated and the children could not be found.
Now, that's a very good illustration of a few points of what you see here, including that last point that I put there, like unforeseen development. So like demographers normally will kind of propose a growth rate based on trends and what they saw before. But then really what's happening is something unforeseen, like conflict, displacement, migration, or even urbanization that are not really well understood at the time of forecasting. And all of a sudden, like even 4 or 5 years after the census, everything could have been totally different. Think about countries like Lebanon, Syria, Turkey, with all the migration. Think about a lot of African countries with much more urbanization than people thought about like even 10 years ago. And think about what would have happened in terms of reality versus those projected growth rates. So what Carolina mentioned, that's also a very good illustration of all these things together, actually. There's a final one here on the charts that could go wrong, and that's that infant mortality rate. So the implied value that's implied in the deduction or moving from the live births to surviving infants. Even that is not that always, I mean, that can also be out of whack. So it's also a value that has come down a lot over time. And sometimes we observe that very different values are being used. One thing I still want to say is that for the CBR, so before, EPI actually guided countries to just use a fixed conversion factor, for example, 3.5% or 4%, and just calculate 4% of your population and say those are the children. And that is really not that useful anymore, because we see so much variability. For example, there's only a few countries that are actually above 4%, and only maybe 10 countries or 15 countries in the world are above 3.5%, but they're still there. And at the same time, you have countries with 1% or 1.5%. So what could go wrong? Basically, everything in that formula can go wrong in terms of projections. Marta or Karina, do you want to add something to that, or?
No, I think you covered the main points. That one other important thing as well, that some of these variables can be different in country per se. So even if you have a growth rate for birth, for example, as Jan mentioned, it can be very different in the urban areas and in the rural areas. And in some areas, it might be a positive number, and in other areas, it might even be a negative number. You might have a fewer births from one year to another.
Yes, and if you would ask people to raise hands, like how many people have a situation where they have a declining cohort or declining number of children in the countryside or in rural areas and a higher number in the urban sites, I think there will be a lot of countries in that situation. And that's exactly for what Marta said, that often, for example, a growth rate might be applied uniformly across the country where that's not really in line with the demographic shifts in that country. So that's also very important to note. Right, so let's just say a lot of these things are actually quite complex to do, and what we will come back to when we say on how to improve that, a lot of it will actually depend on programs working together with demographers and National Bureau of Statistics, because a lot of these things are stuff, as I said, don't try this at home. But it's good for you to know what the limitations and the complexities of that are. Something else I wanted to highlight, and this is actually a little bit of a complex graphic, but I will talk you through it. This is a graph that comes from a registry, an electronic immunization registry in Bogota in Colombia. And what you see here is on the vertical axis where children live according to their record. And on the horizontal axis, you see where they were actually vaccinated. So the implicit assumption here is that we in EPI, we often think of catchment areas, right? You say there's one health facility, and that one health facility has its catchment area, and people that live in that catchment area will go to that health facility. And if that would be true, then everybody would be vaccinated where they live. And that is actually highlighted in that yellow line. And you see that indeed most of the children are actually vaccinated where they live, but most is only about half of them, because like a lot of them are in all these other boxes. So basically, no matter where you live in Bogota, the chances are, I mean, you could be vaccinated in any of these other locations and vice versa. So the problem is that this illustrates very well that kind of coverage monitoring at the lower level becomes extremely difficult, especially in a place where people are mobile. So coverage monitoring and using population estimates at the district level might still be feasible, but at the health facility level, it becomes actually a very difficult exercise to do, and maybe not even useful to even try. Marta and Karina, you interrupt me if you want to join in.
Just to add that this is maybe more problematic in big cities, and also where the private sector may be a factor, that basically they don't have a catchment area. They really vaccinate people from anywhere in that area, in that locality or city.
That's a good point. And I think it is more problematic in big cities, but I think even in rural areas at the district level, it's okay. But at the health facility level, I think people still have a choice of where they go, and they might rather go where they work rather than where they live or something like that. So all of that is possible. Or they might go to a private sector or an NGO or a big hospital rather than the very close by health clinic. Which of course makes it a challenge, because if we use, for example, denominators for vaccine distribution planning, the vaccines will end up in the wrong places. I have 5 ideas to improve denominators and targets, and then I actually will hand it over to Rocco for kind of like the bigger part of this webinar, which is about geographical information systems. But the first idea is to make sure you get the basics right. So we quickly showed you like the basic parameters that are needed to get your demographic data and the population estimates. But to make sure you use the right ones is not always easy. So we think you need to kind of have an exercise led by the national level in collaboration between programs, HMIS, and the National Bureau of Statistics to make sure you get the best possible data. And that includes, I mean, I added a resource document on the bottom, which is called Assessing and Improving the Accuracy of Target Population. And I will put that also in the resource folder. But the idea is that there's kind of an assessment step and then an improvement step in there. And it's not that easy, so you will be able to see that when you read it, but it's something you could do together with people from the National Bureau of Statistics. So first of all, you could compare your estimates with UN population division estimates or other sources and flag differences. We talked about that not using fixed conversion factors, adjusted birth rates, the growth rates, and make sure they're plausible. What we would also like you to do is kind of, when there's kind of a break in the tendency, when you start using new population estimates, that these changes would be applied retroactively, because what often happens is that the denominator changes in a country that they use and the coverage goes up or goes down, but it's not because of an improvement in the program, it's because of a change in the denominator. So ideally, you could also kind of develop denominators going back and have a more smooth line to actually do your coverage monitoring. Number 4, make sure that the mortality rate that is implied in the surviving infant calculation is not too large, is actually not out of whack and in line with other estimates. What I didn't mention in number 3 is kind of when you do the growth rates, if you look at the changes year over year, these growth rates shouldn't be excessive. So typically it's possible that in a given year, the numerator drops a lot or changes or increases a lot because of campaigns or because of stockouts. But it's actually not plausible that the population changes so drastically year over year. So I would say difference of more than 5% are suspect and difference of over 10% are actually very implausible unless there's a specific situation of like mass immigration or migration. And finally, make sure that specific demographic values are applied for subnational projections. So as Marta said, not the entire country will have the same demographic evolution. So it's important that, for example, cities have a different growth rate than countryside, etc. Make sure to get the basics right. Second suggestion would be to use triangulation to improve inter-census estimates at the district level. And here UNICEF is actually working on a guide for this, but while this is coming out, what it really is about kind of using adjustment to district denominators between censuses. So between long periods of censuses, you might want to actually look at demographic trends and use other data, for example, from CRVSs or headcounts or community registers, and compare those with your census-based estimates to make sure that they're still aligned. And if not, kind of, even if you can't change the targets, the denominator for coverage reporting, you might want to change the target for operational planning and everything, at least, where you see that between censuses, there are so many differences that need to be taken into account. Carolina and Marta, I'm just going ahead and you stop me when you want to add something, right? The third one would be a bit maybe, would not always be possible, but empower districts to translate denominators into meaningful facility targets. So what we said is that at the facility, at the health facility, the denominator as such, as a population estimate, doesn't necessarily make sense. But you might, as a district officer, want to make sure that you give reasonable targets to your health facilities that are feasible and challenging, but that are not, as I said, that are not excessive and are not too low. So basically, for example, based on last year's achievements or on the typical number of patients that a clinic normally serves, give them targets and kind of distribute the official denominator that way to your facilities, rather than trying to come up with a real denominator. The fourth one I won't talk a lot about now because I will hand it over to Rocco in just a few minutes, which is to use geographical information systems for planning and even for population estimation. And then the last one, before I hand it over and have one more quiz question, to develop local solutions for specific situations. And what could those specific situations be? Well, we thought about the following possibilities, at least, the theme of urbanization and the development of slums. So we know that population estimates are often not useful in that case anymore, especially if you had high growth in those slums recently. So there you might really want to work with community leaders to notify new arrivals, have like a head count or local registry, and actually use that for planning and make sure everybody gets vaccinated and identified. Sudden migration and internally displaced people because of conflict, drought, famine, these kind of things. That's a very specific situation that is kind of often temporary, but the temporary part can last a long time. And there's some ideas, for example, using specific targets or catchment areas for camps, or specific targets that you add to your normal denominator for refugees or migrants or things like that. Seasonal workers and nomadic people, that's again a different problem, because they might, according to the time of the year, show up in one area or the other. And that's also very difficult to deal with. So in terms of the target planning, I think the only good thing about that is, the positive thing about that is that movements for nomadic people are often can be foreseen, and then therefore can actually also be put into the targets if that's useful. So those were the 5 ideas for improvement. I don't know, Marta or Karina, as I said, jump in if you have any other ideas or you want to add to that. But if not, we'll move on with geographical information systems.
No, that's great, Jan. Just to reemphasize that whenever it's possible, and if you have a chance, then talk to the statistical offices, talk to demographers. They can really be very useful resources, because it's all science behind counting people.
Yeah, absolutely. So as I said, don't try this at home. Do it with experts. Before we hand it over to Rocco, I have one final GIS question, and that's just about your experience. Have you used digital maps for visualization, for planning and micro-planning, to identify the unreached, to track campaigns, and to estimate denominators? And you can click on each of these options, or only a few of them as you have experience. So the options are using digital maps for visualization, for example, for performance monitoring. Have you used them for planning and micro-planning? And I'm talking about digital maps, not just the croquis or the handwritten maps that you use and often see in districts, but have you used kind of Google Maps or something like that for planning, to identify unreached settlements or unreached communities, to track campaigns, and to estimate denominators? And yes, this is just as we expected. So a lot of people have used digital maps for visualization. They're often part of a dashboard in your DHIS2 or in kind of another digital system. And they're often used for performance monitoring to, for example, map the coverage or pinpoint the vaccine preventable disease outbreaks and things like that. So almost all of you have used that for visualization, a little bit less for planning and micro-planning, but still quite a big percentage. Only about half to identify the unreached and or to track campaigns, and very few have experience with that to estimate denominators. So this is more or less as expected. So then, Rocco, if you're ready for your part of the show, I'm going to move it on to you. I will have to move the key, so please tell me next slide.
Okay, great. Thank you, Ian. And that question was a very good introduction to the topic, I would say, because as we see the predominance of using GIS for visualization, which I assume will mean for production of maps or displaying indicator over the more complex tasks such as estimating denominators and so on, is a bit of a demonstration of the fact that there are geospatial techniques available out there, and there are good examples of concrete and uses that had impact on the immunization programs. But not always this is deployed in countries in a systemic way. And I will focus a little bit on that after having given a little bit of overview of some of the applications that we have seen and we believe have a potential to solve some of the problems around immunization programs. I've seen many people from many countries where geospatial data and technologies have been deployed, like extensively, like in Nigeria and India. So some of the materials might not be entirely new to many, but I hope I can give a bit of a contribution in terms of the application. So just a quick introduction. I work at UNICEF and I lead the global activities around application of GIS with a focus on immunization programs, but also a bit widely in health programs in general. And before UNICEF, I was working in Bangladesh, where I supported mapping outreach in urban slums of emergency obstetric care programs. So in today's presentation, I'll give a quick review of some of the ways in which geospatial data technologies have been applied, with some focus on the denominators, but with a wider scope than that. And I will touch a little bit at the end on some of our observations around implementation of this type of data in a scaled way in countries. I shall have a bit of a disclaimer that not all the material presented here is work done by UNICEF, so I have included references in those cases. And I'm not also being comprehensive around the potential applications, but these are those that are more strike me as having potential. So we're in the good slide already. Just a quick background. It's important to set some terminology. When we talk about geospatial data and technologies, it's good to understand that there's difference between data about the locations of objects and geographic features, which is what we call geospatial data, for example, the location of a health facility, and what we call geographic data, which is when you connect any attributes to the location of an object. For example, the number of doctors at a health facilities are not geospatial data, they are attributes that are linked to the location of the health facilities. And this becomes together geographic data, which are the connection in between the location of any particular object and all the attributes that can be attached to them. We also define geographic information as the elaboration of the geospatial data and geographic data into new added value to answer questions. For example, when we estimate the distance in between a village and a facility sites, or we map the catchment areas from the location of the health facilities, we have created new geographic information that did not exist in the original geospatial data. And the fundamental characteristic of geospatial data is that, as you can see here on the diagram, is that they can be related to different kind of data can be related to each other based on their position, so based on their location. So this is like the same way as, for example, in a library we would organize books based on a topic. Geographic information is organized based on where things are, and this allows us to cross-reference very different type of information. For example, the topography, the location of health facilities with geographic barriers, or with information on indicators of coverage, for example. They can all be connected with each other based on their location. So moving on to the next slides, the main technologies that are involved in the geospatial data analysis and management are three. What we now call global navigation satellite systems, GNSS. Most of you will be familiar with GPS, global positioning system. Because now there are a wide variety of satellites, we now call it GNSS, which covers a larger variety of systems. But overall, they are allows us to pinpoint locations on the surface of the Earth, and you probably many of you have done that with a GPS receiver or simply with your phone these days. Through communication with the satellites, we are able to say, for example, where exactly a health facility or a village is located on a map. The second source of geospatial technology type is remote sensing or data from satellites, which are now more widely available. The GNSS and remote sensing allows us to capture the location of objects and features. So they allow us to collect geospatial data. On the other hand, what we call GIS, which is Geographic Information Systems, is a collection of computer software and systems and procedures that can ingest, manage, and analyze the data that are coming from the GNSS and the remote sensing. So it allows us to manage, analyze, and adds a lot of value by analysis of the input geospatial data. Generally, when people talk about GIS, they think about maps, but it's important to remember that GIS covers this spectrum of data, technologies, procedures, and people, and it's not just the map itself. Next slide. Thanks, Ian. There's largely two types of geospatial data that we deal with. Vector data formats are a way of representing the reality, a way of representing the world with simple points and lines and polygons. This type of data represents the world using very precise coordinates, and is, for example, used in the case of points for locating health facilities, in the case of lines for roads or rivers, and in the case of polygon features for things like administrative boundaries or health area boundaries or catchment areas. The second type of data, geospatial data, comes as a raster format. In this case, for example, we use this to represent on the lower left a digital elevation model, the elevation of the terrain or landscape features, like in the satellite image on the right. They have in common that they are not precise points, lines, or polygons. In this kind of data, the information is represented on a regular grid, and for each cells of the grid you have a particular value. In the case of the elevation, it will be for each cell of the grid you would have a elevation of the terrain, and in the case of the image you would have in the case of the satellite image you would have for each cell a value of radiation that is detected from space, that gives you overall that optical image that you can interpret as a photograph, essentially. So these are the two different type of data. Everything that we think can think of can be represented in one of these ways, and all these layers can be stacked up on top of each other in a GIS software, and analysis and relationship between them can be analyzed. For example, we can take the points of health facilities, we can relate them to the lines of road networks and calculate distances to another point layer, which might be a village, through this combination. Next slide, thanks, Ian. So moving on to, this is a very basic understanding of what geospatial data and technologies are. when we think about the application of this in any kind of program or in the health programs, we should ask ourselves, what is the geography? How does geography comes into play to describe the immunization program? So the immunization program involves the interaction between a number of elements, of entities. For example, there are community health workers, there is a target populations, there are the health facilities where the vaccines are delivered. All of these objects we think as individual entities that can be represented and captured in various ways in the GIS software. And in addition to that, we also have the connecting environment. The connecting environment will be the road networks, the administrative or reporting divisions, and the landscape features like rivers, terrain, and land use. The population needs to move through these elements to reach health facilities and vice versa. And so this is the way they are, the various elements of the immunization program are connected to each other through GIS elements. Using geospatial data technologies, as we've seen before, we acquire information on all these entities in various ways. For example, for road networks, we can extract them from satellite images. For administrative reporting divisions, we can measure them or delineate them from a map, from an existing map. For target population, we can detect them for using satellite images merged with sensors or other ways that I will go on a little bit later in a few slides. Next slide. So I'm gonna just do a quick review.
Rocco, before we go into this more concrete part of the presentation, we normally pause for questions, and I would have done it after your presentation.
Yeah.
The fact is that Carolina and Martin, I forgot about that, they need to leave in 10 minutes. So
okay.
we'd like them maybe to be involved in some of the questions. So can we just take a quick break for some of the burning questions?
Absolutely.
So let me just turn to the Q&R box. And actually the first question, which is there twice, is about AFI. So the person, Danjuma Makoshi, appreciate the webinar and the series of webinars and wonders if we can cover AFI. So let me reach out to colleagues who could work with that and see if we do an additional webinar, but it will be then communicated. But let's take that into account, given that there's so many likes for that suggestion. It seems a lot of people would be interested in that. And then I have some questions on denominators, maybe that I can bounce to Carolina and Marta before you leave. The first one is a quite difficult one from Kelvin Siafa Boima. It says, though most of the denominators come from census, the censuses may not be correct. What can we do if we are to use them? And then related to that, I think Patrick Martin asks, how can we address the political manipulation of denominators due to political interest gains and allocations of funds, which I think is one of the challenges behind censuses. So not an easy question, but Carolina or Marta, do you want to expand on those?
Those are the really difficult questions because you cannot just change the numbers or have an influence to do a census yourself as an immunization person. So basically you are probably to be measured against some targets that are affected by some of these factors as was presented earlier. So I think the important, you cannot fix the denominator in that case, right? So what you can do is pretty much focus on your numerators, what you can do, and make sure that you're vaccinating the people that already have come to you, that you know they came to you because you have them registered for the first dose of Penta, for example, the first dose of polio, etc., and keep working on that. For the denominator, again, you want to make sure that your population is vaccinated, even if the number that is given to you, it may be not correct. So you have some tools, for example, to do rapid convenience monitoring to check the people being vaccinated or not and understand why they are not vaccinated. So I'm not solving the denominator problem by any stretch of the imagination, but you at least are being responsible as an immunization person to vaccinate your population of interest, of catchment or the people of your country, basically, by doing your part of the work correctly. It's sad that we cannot give you a solution, but you can raise awareness so maybe people at the national level can work with the Bureau of Statistics, with demographers, to work on improving the estimates of population. But in the meantime, what you can do is to make sure everybody's vaccinated in your area by trying to get a sense of how people are being reached, and if not, why not? Marta?
No, I think that's it. You can use the so-called operational denominator, which is your own estimate or adjustment, what you have with the political numbers. And meanwhile, also in the discussion with the authorities or with your national counterparts, you can use the data triangulation to somehow illustrate some of the issues you have with the denominator provided to you. But unfortunately, it's not a formula to fix this problem.
Yes, and this is also like a question together with a suggestion from Mohammed Hamayoun, who says, as we are unable to have accurate denominators, so can we use it only for logistics and purposes and not for indicators calculation? So I think this is what Marta refers to as an operational target. And I think if you think about it, the most important thing is that at the operational level in districts and health facilities, people work with a realistic target that they can use for program planning and making sure that everybody is vaccinated. So we would actually encourage that kind of local target setting, even if your official denominator that you publish in your official bulletins as well, according to the official denominator, this is the coverage, which might for some areas or even, might for some areas and lead to kind of coverage over 100%, which then probably highlights the deficiency in denominators. And then I'm going to, with the same person, Mohammed Hamayoun, also asks, and I'm going to ask that to Carolina and Marta before they go as the last question, that the growth rate is different in the same state for a particular geographical location. So the censuses can be biased by some percentage. So what is the percent accuracy that should be established? So I guess this is a question about different growth rates in different contexts of even the same state. So what would you recommend in terms of using different growth rates?
We would say that you really need to work in your own context, right? So you need to understand what's more appropriate in your country and within your country where you work. And that would be in collaboration with the Bureau of Statistics, most likely, that they do have the demographers to help. Unfortunately, there is no one formula that can solve it for everyone.
Right. And then maybe a final question, Tariq Masood asks if denominator is also an issue in developed countries like the USA, UK, and others. And can you please elaborate how these are managed and is it quality?
Yes, these developed countries also have problems with the denominators. They also have problems of migration, people moving from one state or district to another. They also have problems with estimating movements. They also have censuses that present challenges, etc. So for the US, for example, to monitor immunization, besides the admin method really of how many people you think you're going to have and how many you vaccinated, they really use surveys, periodic surveys to estimate coverage. The UK just presented a very good, wrote a very good paper. If you look at the bulletin of the WHO, just this month or last month, fairly recent, by a former scholar alumni, by the way, Dr. Michael Edelstein, where they triangulate the information to better understand vaccination, because all the data sources have some issues. So they are using triangulation from different sources. In the chat, I'll put the name of that paper if you want to find it. Thank you.
Well, thank you, Carolina. I think somebody in the chat also said objective is to use all available information and strategies to get children vaccinated, reach every child. So I think that's very well said. This was Olivia Ateba Ikwolo. And I think that's very well said. And to be honest, denominators is only one part of that all available information. There's more information than that. And you're right, the most important thing is to make sure everybody's vaccinated, even if your coverage is over 100% already with your official denominator. So I think Carolina and Marta, you probably have to kind of walk out of the session soon. So thank you very much anyway for joining us and explaining those things to that and sharing the answers with the group.
Thank you for the invitation.
Thank you.
Thank you. And then, sorry, Rocco, but leave it back to you. So I'm sorry for interrupting it halfway.
Sure. Yeah, there's some questions about GIS in the Q&A. Should we answer them now, or do the slides and then do a final Q&A?
It's up to you.
Maybe let's finish the slides and then we can go through the Q&A towards the end, because I might answer some of the questions as we go. Does that make sense?
Okay.
Okay, great. But thank you for all the interesting questions. Well, just in terms of applications, as many of you probably know, one of the most tangent impacts of GIS has been in the use of microplanning. Generally, maps used for microplanning are hand-drawn maps of health areas. Like this is an example here from Nigeria, northern Nigeria, I believe. We generally organize immunization microplanning based on approximate location of the villages and geographic features in the health area. This creates a number of inefficiency, mainly missed villages that are not accounted for. It creates lack of accountability to a certain extent, because there's this inherent bias of the people that is actually responsible for particular areas and are the same that create the map themselves. This is an example here of the kind of maps that can be achieved with relatively simple means. This does not even include necessary satellite images, but essentially using ground field GPS acquisition to map out the villages and health infrastructures that are in the area. There are also administrative boundaries that have been determined based on the location of the settlements to support better definition of health area maps. This can result in a number of benefits: better planning of resources, better targeting of settlements and hamlets that might not be covered by particular vaccination teams, and overall improvement of a more efficient deployment of resources. And on the top you had the kind of maps that were available for the area before any of this exercise was done, and this is in the context of the polio activities, which responds to some of the questions in the Q&A earlier about can we leverage the legacy of the polio campaigns. And some of the data collected through polio campaigns remain as geospatial information, for example, the location of settlements, and this can surely be helpful for the EPI microplanning phase. Next slides. This is another example coming from India, from Patna urban areas. Again, use of microplanning. In this case, the problem that had to be solved was mainly the gaps and overlaps in the respective service areas of various vaccination teams. Through this was a big collaboration of many partners that used satellite images to better identify the road networks in dense urban areas, to better delineate the road networks, and subsequently acquisition of GPS location of all the health infrastructure and the vaccination sites, the outreach vaccination sites, allowed better planning of the service areas so that there was no gaps and overlaps. Essentially, we went from kind of a relatively blind distribution of health service areas with gaps and overlaps in between different vaccination teams, with a more organized and accurate subdivision of the urban area, with clear definition of responsibility for each manager and for each associated to each area. And it also allowed to identify issues of accessibility through distant network distances across the urban area, to identify area which would have a higher accessibility issue. So these were two examples of microplanning. Next, I'm going to move more into the going in the direction of denominators. The first step from using satellite image for improving mapping of any kind of population is the classification of satellite images. This is an example that shows how clearly in images taken from space, the type of neighbor residential area is associated to different geometric disposition of buildings and density of buildings, from very irregular slum areas in, for example, type A, to more spaced out buildings in more affluent residential area, for example, in type F. This is again an example from Nigeria, I believe, where an automatic analysis of this data can result in a classification of the urban environment based on a division of type of residential area, from slums to semi-slums to more residential and industrial. Obviously, this can support better planning, but it also, to a certain extent, is a map of social disadvantage that can be used to better target areas of disadvantage during the microplanning process. Next slide, Ian. So in terms of denominators, as we're talking a lot about that, I see two main type of approaches that have been used to obtain population estimates that try to solve some of the problem associated with census, CRVS, and the other typical traditional sources of information. One is the top-down approach, or what is called the top-down approach, whereby we still make use of the census, but instead of having only information from census over a large area, the total population is redistributed within the census areas using a variety of geospatial techniques, including machine learning and artificial intelligence. Also, to some extent, automatic detection of building locations within the census tract, and distribution of population within these more fine, high-resolution areas. So some example products from Facebook and Season high-resolution settlement layer, which is down to 30-meter resolution, meaning we obtain population estimates for 30 meters, and the most common WorldPop population density products. These are not limited to population density. There are more and more available also for population social demographic and estimation of poverty. I should mention that these approaches still make use of census information, so they are still associated to the availability of census, and they are not more frequent than census information. They essentially provide more higher resolution distribution of population that can potentially support more targeted interventions within census areas. The next type of approaches, next slides, are what we call bottom-up approaches. This tried to unlink from the necessity to have census information by using satellite images and microcensuses. So the step is to use high-resolution satellite imagery, do the classification of the type of neighborhood that we've seen before, and then do targeted microcensus that to estimate a density, an average density of population for each type of neighborhood. So for slums, we could have, a higher density of people per square kilometer. For residential areas, we might have a lower density of people per square kilometer. This is then these average densities are then used to estimate population across the entire satellite image. This is the crude way of doing it. There's a more and more complicated way of doing it. It somehow unlinks us from the necessity of having a census, but these are still estimates. They have a certain uncertainty. So I think the question begs is what can we use them for? What should we not use them for? I think they can be useful for planning. When we can accept a certain level of uncertainty, when in situation though where we actually then need to know exactly the number of kids that will be available in a village, I think we are still far from having that level of accuracy. But there's some use to this product for planning purposes when we can accept some level of uncertainty. Next slides, please. This is a striking example from Nigeria, one of the most impactful application of satellite images that helped reduce the number of chronically missed settlements in northern Nigeria. Satellite images were used to identify all villagers and hamlets, and the information was provided to ground sampling teams for microplanning of purposes for the campaigns, and through a sequence of, as you can see at the bottom here, through a sequence of multiple revisits, they managed to reduce the number of villages that were not visited. This provides a high level of accountability with respect to hand-drawn maps, because as Ian was talking earlier, we don't have the inherent bias derived from the fact that the people counting the villages will be the same people that would have to reach them, because there is evidence from satellite image on the presence or not of villages. So this is kind of an example of the improved accountability provided by geospatial information. Next slides. This is very similar type of application, using GPS to track vaccination teams to support near real-time coverage. What is done here is vaccination teams can be tracked using GPS inbuilt into their mobile phones. This can be displayed on satellite image, and on the left and on the right you can see two different sessions of the campaigns where, by analyzing the missed buildings from the first campaigns, they were better able to target the second campaigns in the right places that had been missed before. So again, improved accountability and more efficient deployment of resources to reach all the population that needs to be reached. Next slides. Finally, this type of monitoring of vaccination teams can be translated into dashboards. This is the dashboards from the Nigeria vaccination tracking system that allows a real-time review of the geographic coverage. We're not talking about effective coverage, we're just talking about a geographic coverage, meaning was a particular village reached during the vaccination sessions. But this allows to solve some of the problems around missed areas. This also partially responds to the questions that was earlier put in the Q&A about, are geospatial data then used outside of the system? And this is a web-based dashboard that displays and exposes the results of the geospatial data and the GIS analysis without the need for GIS expertise. And there's more and more of these dashboards made available to make sure that non-technical GIS people can access this kind of information. Next slide, Ian. So I'm moving to a slightly different topic. We're looking here more at the actual...
Sorry, Rocco.
Yeah.
We normally take keep some time also for questions, so if you can maybe accelerate a bit.
Okay, sorry. I know I'm bad at being lengthy. So this is just an example of using disaggregated coverage, DHS coverage surveys to obtain information on coverage at finer scales than the traditional DSS regions. Next slides. We applied this to provide alternative sources of information on coverage than the routine immunization. So we compare, for example, the routine immunization from DHS2 with the DHS specially modeled coverage over over a small area like wards, and there was good feedback from the district managers in terms of the benefits of triangulation of the sources of information to provide better data quality information on the routine data coming from DHIS2. Next slides. Another application of the spatially disaggregated DHS surveys is look at inequities. Generally, we have information about differences in coverage between socioeconomic groups only at the area regions where the DHS surveys are representative. Using geospatial disaggregation, we can start looking at different areas of the countries which might have more of a difference in coverage between socioeconomic groups, in this case, education. So this is work that is ongoing on improving subnational coverage and equity assessment. Next slides. We can combine this disaggregated coverage mapping with information on density, population density, to identify areas that have both low coverage and high density. This is a number of countries in the Great Lake regions, going from Mozambique to Kenya and DRC. And this is published examples of using spatial models of immunization coverage across countries together with population densities to identify area hotspots of low coverage and high population density. So if we're running out of time, I would move 2 slides ahead, Ian, and just show an example of using GIS to map geographic accessibility to health facilities. As we all know, geographic accessibility is one of the major determinants for access to health services, and we are able to assess the travel time to health facilities, accounting for population, for geographic barriers and different travel scenarios. In this case, in Haiti, we mapped the travel time to the nearest health facilities, and we're then able to assess which of the provinces have a higher number of people, which is more than 2 hours away from health facilities. And this can be applied to vaccination sites as a planning tools for sub-district level monitoring of accessibility. So I would like to, after this few examples, just conclude with some observations about the main, we've seen the main benefits here of GIS in terms of, next slides please, Ian. Main benefits: the ability to improve the visibility of settlements that are left behind, identification of gaps and inequities in access and utilization, optimization of resources allocation by providing better maps of area, and also strengthening accountability by providing evidence of unbiased evidence about areas that needs to be reached. Next slides. Some of the big challenges that we see in terms of moving from individual applications to wider deployment across countries is the existence of an institutional framework for managing and using this data. The availability and the maintenance of national georegistries, vaccination sites, health facilities, villages that are constantly changing, and their locations needs to be updated. And also in many cases, what made the big difference was government leadership in the acquisition and analysis of the data, and the availability also of sustainable geospatial expertise in the ministry. So finally, we have been, next slides please, we have been recommending that in collaboration with the Health GeoLab, we have been working on a framework to support countries assess and make a work plan for improving their geo-enabling the immunization program and the health information system, meaning being able to sustainably integrate geospatial data and technology into their operations. And it goes beyond the technical capacity, as you can see from this. We need to start from a vision, introducing geography and GIS into the national strategic plans, have a minimum of governance structure in the ministry about managing the geospatial data, have policies that enforce all these kind of elements, and also have access and resources to apply the relevant geospatial technologies, such as access to satellite images and so on. And I will stop there so that we can leave time for questions. And thank you again for your interest and for your listening.
Yeah, thank you very much, Rocco. Thank you, Jan. That was incredibly interesting. So we were really happy to be here to listening to you to learn new things about the topic. So I would like now to see if we can hear from one of the participant experience, remaining 90 minutes before we close the session. It was really interesting, very, very instructive. So we will now see if we can have a contribution of a participant who has an experience of working with the subject that we work on today. So I will turn myself to Beatrice Mugari and see if Beatrice Murugari can please just click on your microphone and you'll be unmuted and we'll be able to hear from you. Beatrice? So good afternoon, Beatrice. Can you hear me? Can you talk to us? You just have to click on the mic. So while Beatrice have maybe some mic issues, let us turn to Naomi Hagen. Naomi Hagen, good afternoon. If you can hear me, please just click on your mic and we'll be able to hear from you and from your experience with denominators or GIS. Naomi? So unfortunately, we can't hear from them. Let us turn to Shadrach Anderson. Shadrach Anderson, good afternoon. Can you hear me? Can you just click on your mic and we'll be able to hear from you. Good afternoon, Shadrach. So it's quite difficult to have the mic. So let's see if Kangashal Kenga. Kangashal Kenga, good afternoon. Can you hear me? If yes, please. Okay, so good afternoon, Shal.
Hello, good afternoon.
Good afternoon, Shadrach.
Hello, good afternoon. I can hear you. My question is, what about those whose country challenges when it comes to using of the geospatial data as that's the GIS and other satellite softwares? How do we handle it, or how do we control ourselves, or how do we take care of those tasks? Thank you.
Rocco or Jan, were you able to hear from Shadrach? Because me, I couldn't hear the question.
I think the question was about what about countries that do not have access to data satellite images, and how can they go about procuring and having access to this kind of informations?
Yes, so please, Rocco, please, if you can then address the question of Shadrach.
Yeah, so I mean, the availability of satellite information in itself might not be. It's part of the data that we need. Some of the data, like satellite image, are becoming increasingly available through global consortiums. For example, the GRID-3 project that is led by UNFPA and the Bill and Melinda Gates Foundation is providing this kind of satellite images and derived products on villages for a number of countries in sub-Saharan Africa, and it will probably expand to other parts of the world as well. And in terms of other geospatial information, such as health facilities, locations, for example, this is guidance can be provided for countries to deploy the right devices to be able to do a census of health facilities, or to a certain extent, this can be integrated into the work of district managers if a good place for maintaining this list of health facilities can be found. One of the possibilities is in certain countries is maintaining the DHIS2 systems, where there's a list of health facilities, and with geospatial coordinates can be added there. One of the difficulties with all of that we've seen is making sure that there is a clear mandate in the ministries about the maintenance and the acquisition of this data. And to a certain extent, national agencies, there are existing national agencies that can maintain and source information such as satellite images. Using structure like national spatial data infrastructures, where all the relevant agencies that are need access to this kind of information get together to make sure that this data are available and accessible to everybody. It's also one of way that many countries have been using. Over.
I just want to add to that, because I think the question is also a little bit bigger, and I think I've been asking myself a bit the same question. It's like every time, so I've seen a few of these presentations, and it's also it's always very interesting, and the possibilities seem very interesting and seem like they really could help boost the immunization programs. But then if I'm thinking about this webinar, for example, let's put myself in the shoes of, let's say, an ambitious district officer sitting in Ghana or Pakistan, and maybe I don't have access to polio money or no partners helping with that. And I understand that a lot of things need to be in place, but my question is, where can I start? Even if I would be interested to kind of explore some of the possibilities, what can I do myself without waiting for funding and partners and satellite imagery to be available? And I think the key is often to probably start simple. And I think Rocco showed a lot of possibilities, and they go very far, and the 5x5 population estimates and everything. But maybe it's better actually to start just looking at Google images and satellite images, and already using those, for example, for micro planning instead of the hand-drawn croquis. Right? So that's something that can be done. The other part I think that is also feasible, or a little bit more feasible, could be the identification of missed settlements. So yes, if we can really look at satellite images and try to find those, even if it's kind of without any algorithm, we can probably get a better idea about the catchment area. But I do agree that a lot of the promise of GIS is still a promise, and that a lot of work needs to be done before actually ministries of health can be empowered to really use the full advantage of that.
Thank you very much, Rocco. Thank you very much, Jan. And thank you, Anderson, for your question. I hope that the explanation given by Jan and Rocco was very helpful for you. So thanks to all, Jan. I would like us to see, to look behind the perspective for the future, for the next meeting that we will have next week. So please, can you tell us about what are we having in the menu, on the menu next week?
Yes, let me just share that. So next week, we already have the last webinar again, and we will do it on electronic immunization registries. Somebody asked, can we also do one on AFI? And we haven't planned it, but we can definitely think about doing that, and maybe have a bonus webinar still in December, maybe on AFI's adverse events following immunizations. So with that, the electronic immunization registry is also a hot topic, and it's very kind of up and coming in many countries. So with that, I think we can close the webinar. So I just want to thank Rocco for preparing the slides and for joining us today and kind of presenting it. sorry to the participants if you couldn't ask all your questions or share experiences, but I think it was very interesting. And a lot of you have said that in the chat box, that this is very interesting, sometimes complex, but also very an interesting presentation. A lot of people have asked for the materials and the slides to be shared. I will put that right now in the Dropbox, where I will share that in like just a few hours or so. Not just the presentation, but also some of the resources that were mentioned, like the Edelstein paper that Carolina mentioned before. So Rocco, thank you. And if you want to say something, now's the time. No.
Rocco?
All right, so I think then we can probably close the...
No, it's okay now because he was unmuted.
No, sorry, I was muted. Thanks for the opportunity. I apologize for going a little bit over time, and I will try my best. If the questions are going to remain open here, I'll try my best to respond to at least some of them before we close.
That's a great idea. I will share the questions with you in like a document, and we can also post it in that same Dropbox.
Okay, great. Thank you.
Thank you, Jan. Thank you, Rocco. Thank you to Carolina, all the experts who were here to respond to our questions. And the topic was really important. And like Jan says, we see a lot of participation. We're glad to have you with us. We really appreciate your active participation. We really want to hear from your experience. And we encourage those who are taking the WHO course at the moment to use all that to develop their project that they are doing now. And we encourage those who are not taking the courses to please think of applying to these courses. And we really appreciate that opportunity offered by WHO. We really want to see you next Wednesday. We'll be talking about EIR. That is a topic that is really important and interesting, and I know that you will be here. Please share the link with your colleague who might be interested. We really want to have you. So good afternoon, good evening, depending where you are. Jan, it was a pleasure to listen to you and the expert, and we hope that the next webinar will be much more interesting as the one that this one. And again, we will share the Q&A answer from the response from Jan will be shared in the resources, so you are not missing anything. Thank you, Rocco, for being available to respond to the question that we couldn't respond today. So goodbye, everyone. It was a pleasure to be here, and see you next Wednesday. Bye.
Thank you, and good afternoon.
Bye-bye. Thank you.